So I just looked at all of the trigger points which I could find from her neck down to her hand. It took approximately 45 minutes per extremity to inactivate all the trigger points. And those trigger points, which I will show you in the next few minutes, were in the trapezius, the biceps, the triceps, the deltoid, the pectoralis minor and major, the coracobrachialis, the brachialis, the brachioradialis, the extensor digitorum, the extensor carpi radialis, extensor indicis, the first dorsal and the first dorsal interosseous. All of these were inactivated bilaterally. After approximately 45 minutes of treatment for each extremity, the patient's pain was gone in each extremity for the first time in nearly 13 years. She had a good range of motion, not full, but a good range of motion. And after 20 minutes, the swelling of both hands completely disappeared. Here's again the various trigger points in the trapezius muscle. This one is reached by going to the front of the trapezius, and this is anterior, and refers to the temple as well as the angle of the jaw. This is a trigger point which again refers to the interscapular area, right in here to the rhomboid area, and various sites. The biceps, both heads of the biceps, both the long and the short head of the biceps, had trigger points, and they refer down to the just below the elbow in the anterior forearm and up to the shoulder. This is often misinterpreted as a biceps tendinitis and can be differentiated from that by simply inactivating these trigger points with a laser, and the sensitivity to touch at the tendons disappears when the muscle relaxes. Triceps, you can see here, can refer down to the fourth and fifth finger in this particular site. In this head of the triceps, you can see actually some referral to the lateral epicondyle and up to the shoulder. And here is a little bit more of the referral to the lateral epicondyle. The triceps is one of the muscles which you have to look at when you have a patient with tennis elbow or lateral epicondylitis, because it in fact may be causing a significant amount of the elbow pain. The deltoid muscle is, as can be seen here, and pretty much is limited to referral just in the area of the deltoid muscle. There are numerous trigger points in this muscle. If you were to inject these distal ones, there's a great deal of burning involved in injecting these, but clearly not a problem when you're using the low power laser. And you can see the various attachments down on the humerus as well as up on the shoulder, the clavicle here, and parts of the scapula. Pectoralis minor and major were also part of this. Pectoralis minor, this is important not only because of the referred pain to the anterior shoulder down to the small, usually the fourth and fifth fingers of the palm of the hand, but also because the brachial plexus and the artery and vein that goes to the arm, the subclavian vessels, pass right underneath this tendon and can give you a thoracic outlet syndrome. Pectoralis major has three major areas where trigger points are found: in the upper lateral portion, the mid portion, and the lower portion. The lower portion gives rise to breast pain and to periareolar pain. The mid portion gives rise to anterior chest pain going down the left arm, as you can see here, and can easily be mistaken for a myocardial infarction. And indeed, often the differential can be simply using the laser on this trigger point and seeing if the pain goes away. These two trigger points, as well as this one, have been associated with stopping what's called Prinzmetal's angina, which is a spasm of the coronary arteries. And if you relieve the pain from these upper and mid trigger points, frequently the spasm will disappear. The coracobrachialis was another muscle which she had, which you always have to look for because it's often hidden underneath the anterior deltoid and can easily be missed when there are deltoid muscle trigger points. And as you can see, the referral pattern goes down the posterior portion, down to the arm, down to the dorsal portion of the hand. Brachialis muscle, again, can easily be missed because of the large biceps muscles that are often here, and can give rise to thumb pain, which is often misinterpreted as either tendinitis or as the early portion of Dupuytren's contractures, or arthritis. The brachioradialis is the primary muscle that's affected and is causing tennis elbow symptoms. The tendon inserts right in the area where patients feel lateral epicondylitis, and this is where steroid would be injected by an unknowing person who didn't realize that the problem was coming from lower down in the forearm, and also can radiate down into the thumb and into the area where the first dorsal interosseous muscle is. This muscle trigger point is activated when the wrist is dropped, which is why you see professional tennis players and other good tennis players using two hands for their backhands to avoid dropping their wrist and setting off this trigger point. When you see people wearing bands around their forearms, it's usually right here over this trigger point and the next one that I'll show you, in an aiming to try to minimize the pain that's referred to the lateral epicondyle, but if you interview these patients, they'll tell you it doesn't really help. The extensor digitorum is the other muscle that is frequently involved because of where it attaches up here at the elbow, and is often has referred pain into the lateral epicondyle and makes wrist flexion very difficult sometimes because it is so tight. And the extensor carpi radialis over here will give you dorsal wrist pain and will tend to exacerbate the problems in the elbow. Here again is a picture of the first dorsal interosseous, which we've inactivated earlier, and you can see that this is often a very important trigger point to evaluate and inactivate with the laser. Now we're going to go to the last case that I'm presenting today. That I have seen quite a few of these patients recently where they're complaining of shoulder pain, and they've been told they probably have a rotator cuff tear. The MRI scans of these patients' shoulders will often say that there is an area of increased, I guess they call it increased signal, that is consistent with a small rotator cuff tear. And then they suggest other things that might be tested clinically, These patients often don't show any signs of a rotator cuff tear because they can move their arm and elevate it quite significantly, assuming that other things are not present, which we'll discuss in a moment. But in any case, often the MRI scan is incorrect, and the problem is truly an easy one to solve with dealing with the trigger points that can be easily inactivated with the low power laser. One needs to look at all of these trigger points, which are frequently present anytime there is any kind of shoulder pathology, but particularly when people complain of difficulty in movement, which is consistent with a rotator cuff problem. The upper trapezius, the rhomboid, the levator scapula, the infraspinatus and supraspinatus are the two major, the tendons of these muscles are the two major components of the rotator cuff. So frequently you'll find these trigger points whether or not the patient has a tear. And often what appears to be a major tear turns out to be a minor tear when you inactivate these two trigger points. But you also need to look for the latissimus dorsi, the teres major. The teres minor can give you a dysesthetic kind of feeling on the dorsal portion of your hand, in addition to giving you shoulder problems. So that's something to think about, again, thinking outside the box. The deltoid, the coracobrachialis, the pectoralis major and or minor. All of these muscles may be involved anytime you have shoulder pathology, and you need to evaluate all of these muscles and palpate them to see if in fact there are trigger points present that you need to inactivate. Once you've inactivated this, the patient may say, gee, my shoulder feels perfectly fine, there's no problem. And you solved their clinical presentation that is just myofascial pain. However, it is not uncommon to find that the active trigger points in these muscles have sort of overshadowed the pain from the underlying pathology. And this is the underlying pathology, an irritation of the acromioclavicular ligament, or the AC ligament. Essentially, when this becomes quite inflamed, you have what's called a grade 1 separation of the ligament. Excuse the spelling error here. You palpate that AC ligament simply by using your finger to follow out along the clavicle, and when you come to the end of the clavicle, the patient will jump if in fact they have an AC ligament problem. And they may not show that at all until you've inactivated all of these trigger points. So remember that you're going to look for this AC ligament. If in fact it's